I will take you through a case which will sort of demonstrate how all this is done in action as a part of management. I must explore the myth that pulmonary embolism is less common in this part of the world as compared to elsewhere. We looked at our own patients. This is an abstract which shows that pulmonary embolism after total knee replacement, despite the usual prophylaxis, does take place, and it's 0.88% out of more than 1,000 knee replacement cases. We suspected this in 26 patients and found it in one way or the other in 9%, in 9 patients. And in medical patients too, in the pulmonary and critical care service, out of 1,980 patients, 89 were suspected and 30 were proven, so that makes it about 0.15. Obviously, this is not a true estimate, it's a gross underestimate, but it's there in our midst. So, better to be wary, because part of the game of pulmonary embolism is being alert to the possibility. So this was a 28-year-old male who had a road traffic accident, and he was transferred with a fracture of the left pubic ramus and various bruises, and there was a shadow on the lung which we thought was contusion at the outset. There were no cranial or abdominal injuries. He was fully conscious but required oxygen supplementation, which we attributed to lung contusion. And a close reduction of the pubic symphysis was done with external fixators, and prophylaxis was given with fondaparinux 6 hours after surgery. You know what orthopedic surgeons are, they don't really believe in prophylaxis, they really push them. He was transferred in the afternoon, and this was the X-ray at the outset. You can see how there's a shadow here. Shadow is a shadow, it could be anything, but we interpreted that as a contusion. He was unconscious in the morning, and he was brought in a hurry to the ICU, hypotensive and saturation of 85% despite a 15-liter oxygen. But at transfer, he was pulseless, BPLS. There was volume loading pressors, he was intubated, ventilated, required oxygen fraction of 1. And opening CVP pressure was 22, is what he looked like with all these external fixators. See, at baseline ECG, you can see, you can appreciate, it's unremarkable. At the point he was transferred, you can see the S1, Q3, T3, said to be rare, but we found it here. And this was the X-ray, which didn't materially change. Echo is very useful in a situation like this, as Dr. Chawla pointed out. Showed RARV dilatation, a normal LV. And blood gas analysis showed hypoxia, high lactate, and severe acidosis. Since there was unacceptable risk of transport, we gave him full dose of heparin and alteplase 10 milligram bolus and a 90 milligram infusion over 2 hours. He had received volume loading, there were 3 presses on floor, there was soda bicarb as well. There was rapid hemodynamic and metabolic improvement over the next 2 hours. There was return of circulation, but you know, there's one guideline that says that you must stop heparin during the course of alteplase and stop it for 2 hours and then restart. This may not be the gold standard everywhere. In some part of the world, they continue with heparin, they continue immediately thereafter as well, but we followed this American practice. There was no anticoagulation for 2 hours, but then we found fallen BP again, severe hyperlactatemia. We restarted in a hurry the heparin infusion, and we transferred him to the cath lab. Catheter fragmentation was done, and before our very eyes there was restoration of beat blood pressure again and oxygenation. And there was recovery of a lot of clot in the sheet. We didn't bother to put a dye and prove anything because it's very obvious we didn't want to risk the patient too much. We placed an IVC filter because another episode of embolism is going to be very intolerable to the patient, having been near death. Heparin infusion was continued, targeting a ratio of 2 to 3. Hemodialysis was started for acute renal shutdown. This gross derailment of LFTs, the enzymes were in the thousands, with rapid resolution over the next few days. And you can see what it looks like. You can see the pH was really, down in spite of bicarb, corresponding lactates climbing right up to 14. And with this rapid restoration of circulation, firstly with alteplase, then with catheter fragmentation, you could see resolution of this hyperlactatemia over the next 2 days. You can see how even the right heart strain, as reflected on the ECG, shows resolution. You can see how it's become upright again. The lead one and the S wave disappeared. So the full-blown intensive care with daily dialysis, mechanical ventilation, sedation, analgesia, and daily ultrasound of the abdomen to look for bleeding because he had a trauma, mind you, distinctly. And we were also doing echocardiogram to look at the RV strain, which was decreasing progressively. External fixators were removed. And on day 7, the hemoglobin dropped. And this is a complication during management, which occurs in about 3% in those who are exposed to fibrinolytic, thrombolytic therapy. But it could be higher, given that he had a recent trauma. So you can see that there's a large retroperitoneal hematoma. So surgical evacuation was done at the same time with internal fixation also done of the pelvis. Intra-abdominal pressure is one thing we must monitor as a part of the intensive care, vital signs. We found it to be high, 25 centimeters. So we took proactive action with sedation, paralysis, hemodialysis, and we promptly also had the pack removed. So enteral feeding, sedation for education, tracheostomy, empiric antibiotics get prescribed, but this is another thing we must really weigh and consider whether what we are treating. The procals were all high, it's very confusing, but we couldn't find really a focus of infection. The gradual weaning and decannulation was done on day 20, and he had been off heparin for about a week after the surgery, so after the bleeding. So we got his thrombophilic screening done and showed antithrombin 3 level of only 37%, while protein CNS were not. On day 22, a perfusion scan showed a large defect on the right side, so the original patch could have represented embolism at the outset. Low molecular weight heparin was restarted, followed a day later with warfarin, with resolution of fever and tachycardia. There was full recovery in 4 months and resumed work, and warfarin was stopped after 6 months. And a repeat antithrombin 3, both in himself and in his brother, showed marginal reduction from the normal. It was about 69%, 72%. So we chose not to put him on lifelong anticoagulation. So this case does illustrate a few points. And if there is a shock, you consider fibrinolysis, that's the gold standard. By the ACCP, it's a 1C recommendation. But if there is no shock, and there's no evidence of right ventricular strain as shown in pro-BNP or troponin or RV size or CT scan, then we can, only anticoagulation is recommended. But if there is RV dysfunction, seen clearly, then we must consider fibrinolysis or embolectomy, either mechanical or surgical, because these are the data of risk assessment. You can see if there is RV dysfunction, no arterial hypotension, mortality is 8% still. And if there is arterial hypotension, it climbs to 15%. And somebody who presented, like our case, cardiogenic shock or near cardiac arrest, so it is very high mortality, 24-64%. Combined clot fragmentation with aspiration is what, if it is available, the expertise available, we should resort to for quick restoration of the pulmonary circulation And in this paper, 16 out of 18 survived from massive pulmonary embolism with pulmonary artery, fragmentation, clot fragmentation. So unless, if there is a major contraindication, there's a real absolute contraindication to thrombolysis, like intracranial bleed, or patient is actually hemorrhaging, or they've got abdominal trauma, or he's got increased bleeding risk due to any reason, or thrombolysis has failed. One must consider this catheter thrombectomy, and of course surgical thrombectomy may be needed if it fails. But 85% of the time, as you can see in this paper, it succeeds. So in a nutshell, if you look at the treatment, initial treatment, then long-term treatment and extended treatment. Initial treatment consists of unfractionated heparin or low molecular weight heparin or fondaparinux. They're all in the same 1A recommendation. Thrombolysis will be discussed in what circumstances you do all these things. So vitamin K antagonists are started simultaneously as you give heparin. And at least for 3 months we sustain in the case of pulmonary embolism. Many of the older recommendations are 6 months. But extended treatment should be considered in some. I'll get to that. An INR target of 2 to 3 is what is recommended now. So you can see you have an extended treatment with cancer, or there is no provoking agent discernible, it's idiopathic. Or if it is secondary to a minor triggering factor, like long-haul flight or HRT, as opposed to a clear provoking agent, then you go for extended treatment. One could consider a less intense INR target of 1.5 to 1.9 when you are giving a longer term treatment. But there are some conditions, say antiphospholipid syndrome and so on, where you don't reduce the intensity of this anticoagulation. While you manage the case, of course, you should be aware of what complications can occur and how to meet with them. In the case that we have described just now, bleeding was the major thing. So that has to be met with discontinuation, of course, of anticoagulation. FFPs, plaque cells and platelets, even if they are not really out of range. Protamine sulfate and desmopressin, of course, because it can stimulate vitamin K and 1 milligram factor. Vitamin K, of course, consider giving 5 milligram rather than full 10 or 15 milligram, because you don't want the anticoagulation to be blocked for a very long time either. You want to just meet with this bleeding complication. Prothrombin complex concentrates are now available, and recombinant factor 7A is also available for this purpose. I want to draw your attention to heparin-induced thrombocytopenia as well. Look at this case, a sleeve gastric resection for morbid obesity, received thromboprophylaxis with LNWH. Readmission 7 days later with intractable PSVT. So an electrophysiological study was done, and radiofrequency ablation. 6,000 units of heparin was given at the table. And the patient came from the cath lab in a hypotension and hypoxia. There was DVT detected in the right leg despite this heparin. There was hypoxia. Platelets dropped from 4.68 lakhs to 2.53 lakhs. The cardiologists believe it is still, those platelets are normal. So they persist with giving unfractionated heparin. There's DVT developed on the left leg. There's a compartment syndrome in the right leg requiring embolectomy. There's hypoxia leading to mechanical ventilation. There's further drop in platelet count. So we diagnose heparin-induced thrombocytopenia on the basis of the 4 T's scoring system, which is more than 6. It's very difficult to get the HIT antibodies done in this country. We had ordered it, but it had to be sent abroad. We still don't have it even at the end of 1 week. Heparin was stopped, and Hirudin was given, Bivalirudin. We lost the patient because it's got a great prognosis. So in HIT, we have got alternatives available, like direct thrombin inhibitors like Lipiridin, Bivalirudin, Arbitrobin. and factor 10A inhibitors such as ganaprenoid and fondaparinux. We don't give vitamin K antagonists until the platelet counts are normalized. We now also have oral DTIs, the dabigatran, which can be used instead of warfarin, which is non-inferior in efficacy and in complications is no greater. But you can dispense, there's ease of administration and you can dispense with monitoring. The chronic form should not be forgotten. There's an 18-year-old boy who had recurrent PEs for 2 years. Both he and his brother were found to have severe protein C and S deficiency, less than 10%. There was thrombolysis done in IVC filter. You can see this case came to me 10 years ago. At that time, this multi-detector CT was not available. So don't miss CTPH. Incidence is 0.8 to 3.8%, depending upon your awareness. And a periodic echocardiographic monitoring after a pulmonary embolism should be done for this purpose. Pulmonary endarterectomy can be curative. I want to conclude by pointing out that new treatment strategies have emerged in pulmonary embolism, and risk stratification should be done, which determines your management strategy. Alternative regimens are being validated, and newer options are available to treat complications. And a new generation of anticoagulant drugs are beginning to be available, which are going to change our practice. Thank you very much for your attention.